So welcome back, everybody, to the podcast. It gives me really great pleasure to welcome back Jenny Barnes, who's going to be talking to us about perinatal mental health again. We had a really wonderful first podcast where we talked all about the impact of perinatal mental health, just how common it is. 1 in 5 women and 1 in 10 men. And we also talked about changing the conversation and changing the language that we might use to make sure that we are not offering judgment and we're supporting our patients as best we can. And we've got lots more to talk about today. So welcome back, Jenny.
Thank you very much for having me back on the podcast, James.
Well, it's great to have you. Well, as promised at the end of the last time, we were going to start with the conversations and initiating them with patients. And the first time we tend to get a chance to do that is the 6 to 8 week check. Got any advice for us?
Yeah, absolutely. So I guess the 6 to 8 week check, as you say, is the probably one of the first times you're seeing mum and baby together in the surgery. And it's a really important opportunity to ask some of those questions that we talked about before. And I just wanted to really get you to have a think about maybe how you do it in your surgeries and maybe ask your colleagues about how they're running it in their surgeries as well, because there are different ways of running it. And there is a lot to get done in a 6 to 8 week check, is the other thing just to think about. So there's a lot of physical things to check, isn't there? You've got a mum check, a baby check, thinking about their post-op recovery, if they've had a cesarean, or recovery post-vaginal delivery, contraception. So there's lots of things to think about. And sometimes the mental health side of it can be the thing that you think, oh, do I really need to ask about this? But it is so, so important to ask about it.
I think that's a good place to start because giving it enough time to breathe and giving it enough time to have those difficult conversations, often a thing that we are chasing in primary care, isn't it? That enough time to give the right care to our patients.
Yes, I think it is just asking those questions really, and being brave, and saying, right, I need to take this time with this family. And in our surgery, we try and get them booked in with a GP that they might know already. So there is a bit more continuity, because a lot of the work around all mental health illnesses, to be honest, and a lot of primary care presentations, is that if we can get continuity in there, then it's really important. And they will have been seeing other healthcare professionals along their care journey as well. So different surgeries will work it in different ways, but I have a meeting with the health visitors, and we talk about mostly about safeguarding cases, but they will bring up cases that they're just a bit worried about mum, which can just give us a bit of a heads up, so that when the doctor then goes into the 6 to 8 week check, then they can make sure that they've just got those antennae up. So I guess it's linking in with your other professionals that we're going to be seeing them as well. So health visitors, or going back to the midwives as well. How do you interact with your midwives? And sometimes that's got a bit fragmented within healthcare, which is a real shame. But do you meet your midwives? Or do they let you know if they're worried about any women at all?
I think that's a real challenge. I reflect that you rarely actually see a midwife or have an opportunity to sit down with them and talk about this really crucial time in a patient's journey in that perinatal period, nor the health visitor. And certainly, I think that there's been a little bit of a change and the service that has suffered through reduced contact and reduced frequency, and then not necessarily joining up all the dots because they'll see them in their home and hopefully it's passed on for you. But I think it's really important that we have really good communication.
Yeah, absolutely. I mean, our midwife used to come into our surgery and do and see the patients, but with space and size, and I'm sure this is going on in lots of other surgeries around the country. But I guess it's just being aware of it and just having a think about it. And just because you've always run something one way doesn't mean it necessarily needs to continue like that. So just have a think about how you're running it. We had a look at actually how we were inviting women for checks. So we do our checks all at 8 weeks. So they just have to come for one appointment. So they come at 8 weeks for mum and for baby immunisations. Some surgeries bring them in at 6 weeks and then back at 8 weeks for immunisations. I guess it's just thinking how you want to structure it, and with that continuity, what do you put in your letter to your families? One's colleague I spoke to, which I think is really nice, and we've adopted it, put in there, if you would like to bring someone who could look after baby while we do your check, then please do just open that conversation, that maybe there are things that they want to talk about that is much easier whilst you're not trying to calm a screaming child who's just had their immunisations down. Or so it's probably just thinking about how you structure it in your surgery. We try. So with continuity, it's really big challenge. But what our nurses do is the nurse that does the first baby immunisation at that appointment actually books them in for the second immunisations with them, so that they then see them through three contacts, with those first set of immunisations, and they can then raise to us if they think that they're a bit worried about the family or what's going on.
Yeah, and I suppose that really comes back to education and all of the good work that the perinatal mental health champions have been doing to upskill surgeries and upskill all of our colleagues, because we'll each have different contacts with them. It's not, no, I suppose, not solely GPs, is it? We're a part of a big team.
Yeah, absolutely. So the perinatal mental health project is designed for all clinicians in primary care, and we've really been trying to reach non GPs, because GPs are quite good at turning up to teaching, but it's getting it out there to other healthcare professionals. And we'll put a link. I think James, you said you could do to our website in the notes, and there are actually some podcasts that my colleague Lucy has recorded as well. And if you want to look at the 6 to 8 week check in a bit more detail than we've got time for here, then Claire McDonald goes through it with Lucy in much more detail about what to include as well within that 6 to 8 week check, which we're not going to cover here at this point.
Well, yeah. Well, I mean, that sounds like a really good thing for our listeners to listen to after this. I think just thinking about how we invite people in and those multiple points of contact that can give us some clues. And I suppose the other thing I'll pick up from our last podcast was about normalizing the conversation, about making it just a common thing that we ask about rather than a thing that we're trying to move through. Um, and taking those opportunities to have those conversations with patients.
Yeah, absolutely. It's just asking that open question. And the more we get used to asking it as clinicians, and the more that women and families get used to hearing it, then it just normalizes it and actually just makes it, part of a conversation. How is your mental health? How are you? Yeah.
Really, really nice way of approaching it. So that's a really nice way of initiating those conversations and making sure that we're taking every opportunity, because we know this has got a really wide reaching effect on both the mother and the child, but also the rest of the family. We touched a little bit on perinatal mental health in men last time, but there's quite a lot to that, isn't there? And a bit surprising.
Yeah, absolutely. I was thinking it's thinking about perinatal mental illness in partners and men. And it's really common. I think we touched on it before. It's 1 in 10 men get postnatal depression. And I was looking at the NCT website and information, and actually 1 in 4, so 25% of men, get mild depressive symptoms, which tend to be more prevalent around 3 to 6 months post birth. So it's really common. But how many times do we ask about partners? And because they may not be there at that consultation. And it's just thinking about it. And we had a nice debate with our nurses in the practice. And they said, well, what do we call that? If a man comes with depression, is it postnatal depression? I said, well, actually, yes, it is. It's still within that. But again, it's that perception that it's the mum and the baby. So it's just thinking about the partners, the dads. And there's multiple reasons that this is going to happen when you think about the changes that are happening in their life. So we've talked about sort of the changes that are happening for women, but actually the dad's world has been turned upside down as well, hasn't it? With, this little bundle of joy arriving there, which the extra responsibilities, your relationship has changed with your partner massively. Suddenly they're looking after your baby, and again, it's the society pressure that this should be the most wonderful time that you've had, and you need to be providing and being the looking after them all. but you may well be trying to work a full-time job as well with some sleep deprivation. And, when you get home, here's the baby you need to look after because I've been looking after it all day. There's all those things that get linked up into it. And there might be financial pressures, and lots going on. So it's just asking those questions. And again, like we talked about, with mum and sort of baby, it may be that they're not coming with mental health, saying this is a mental health problem. They may be coming with sort of irritable bowel type symptoms, or headaches, or sort of non-specific things that I guess as clinicians we just need to. We're good at digging beneath what's going on, but again, it's just looking behind that smile, even, with partners and dads. Actually, what is going on at home? How is everything at home? You've got a young baby. That's really tough sometimes. And it's asking those questions.
Yeah, I mean that phrase "looking behind the smile" really hit home to me in our last podcast. I think there's a lot of pressure on families, on partners, on mums themselves to be smiling and happy, and this is the most wonderful thing that happened to me in my whole life. And yet, but of course, there is a degree of that, but it can really be impacting on their life in a myriad of ways. Um, and I wonder how much modern society and the modern expectation of what we should feel when we have a baby is impacting on that. Have you any thoughts on how social media and how modern life might be impacting on women's presentation, I suppose?
I think it's massive. I think that expectation that we put on ourselves, our families about how we should feel rather than actually just feeling how we are. Because if you look on social media and the pictures that people post, they don't post that you're up in the middle of the night crying because you can't do this, or, baby was screaming. It's that, like the pictures we talked about looking behind the smile, it's everything's fine. I love my baby because people aren't posting the bad things. And I think that's part of the problem with social media and the way we're presenting things to mums, because then it makes you feel even more like you failed. If everyone else is doing so amazingly well, then why am I feeling like this? And that will be the same with dads and same for other family members, to put that expectations on themselves. And there's the stats around. So only 40% of mums feel that they fall in love instantly with their child. Whereas if you looked at social media, you'd think it was over 100% that do, because you put that perfect birth photo on,
And how much they weigh and
and
all
what
of that? Yeah,
their first smiles and all their
yeah.
milestones, but you don't post the struggles that you're putting up. And I think that's, as society, we're putting that pressure on ourselves.
And I think that as, I suppose, community leaders, as general practitioners, helping to normalize that, which is kind of a recurring theme of what we've been talking about, normalizing asking about it and feeling how you feel rather than how you're supposed to feel. Because I think I'd use that to move on to our next point, and we were going to talk about OCD because quite a lot of those feelings that you feel you should be feeling but are not actually feeling, or feelings that you are feeling you don't feel you should be feeling, it's probably a rather complicated way of putting that, are really challenging for a person. How does this fit in with OCD?
It's really challenging. And I think, thanks, James, it's a really important area to talk about for clinicians to be aware of, to be able to ask mums. So, particularly with OCD, it's the intrusive thoughts that women get. So, 100% of new mums will have thoughts about accidental harm to their child. So, 100%, which is massive. But they probably haven't vocalized them to anyone because the perception is that, well, I shouldn't be having this. This is wrong. And these are thoughts of, if, oh gosh, what if I fell over now? My baby would get hurt. Or if I let go of the pram and then they run into the road and get hurt. So it's thoughts of accidental harm. But 50% of mums will actually have thoughts of intentional harm to their child. They don't have any thoughts of acting on them at all, but they will have had thoughts of intentional harm. And to a new mum, that will feel awful. So if we don't ask about it, and if we're not aware of it ourselves, because I wasn't aware of the level of it until I did this training, then we can't help them. Because if we can ask them about it and say, have you had any thoughts about accidentally harming your child? It's really common that women can obviously feel really upset about those thoughts. It's really important for me to know. And just again, asking those questions when we talk to them and when we see women, that will really help them because we can then tell them that it is actually, it is normal to have some of these thoughts and we can then support them.
I think that those numbers there are astounding, really. So 100% of accidental thoughts, and I thinking, every other person has these thoughts of but a possible intentional harm. It's kind of hard to get your mind around, but I think that that's why it's so important that we as clinicians undertake training in perinatal mental health, because you don't want that shock to show on your face, because it is a shocking thing to hear for the first time. But when you recognize that that is thoughts, that's not intentions, that it's really common. We talked a lot about not using the word normal last time. It's really common. um that actually we can help people feel, I suppose, better about that, because you can imagine that it might be the thin end of the wedge into worsening mental health.
Yeah, absolutely. And normally if they can just say that to someone and you can say, actually, half of women get this thought, that's all they need. They just need to know that they're not going mad and they aren't the one that is going to harm their child. Because going on to what you say about the thin end of the wedge, what we all really worry about and we don't want to miss is harm to anyone and to a child. So those stats then go to, so 3% will have thoughts that actually interfere with their life. So we're getting to that end that do need the help from the perinatal mental health team, but less than 0.1% will actually have thoughts of act, it will actually act on those thoughts. And that's where we all worry about missing it. But that's what women will be thinking. Oh my goodness, am I going to harm my child? Well, no, you don't have an intention of it, but we need to give you some support. So it's asking those questions.
And I suppose also going through a parent's mind might be, and and what if I do admit this to my doctor? What are the consequences of that? And I think for us, if without understanding this very well, we might consider that disclosure. We might consider, what do I need to do with this information? So I think this is why it's a particularly fascinating topic.
Yeah, absolutely. And I think it's a lot of the reasons why people don't disclose mental health or struggling with bonding with their child, because what are we going to do? We're going to end up having a safeguarding referral. So 3% actually have thoughts that interfere with their life. But less than 0.1% actually have thoughts of acting on those thoughts. And that's the really important thing to realize is that these thoughts are common, but actually the risk with them that we obviously need to pick up and identify is really small.
Yeah, and I think that's reassuring to hear, of course, because we're always looking for that, I suppose, more serious end of things. We're always looking for things that concern us. And the thing I reflected when we first started talking about this particular topic is that, when people think perinatal mental health, they don't really think OCD, or at least I didn't until I started talking with you. We think postnatal depression, which we've talked about, but also psychosis. What's the impact of postnatal psychosis on patients? Is it common? How can we pick this up?
So, psychosis is the least common presentation of perinatal mental illness, but it's obviously the one that I guess with depression we we hear about the most. It's got the highest risk and women and affects families the most. So it's really important not to miss it. It's the highest lifetime risk of a woman getting psychosis is in the postpartum period. It normally happens in the first few weeks after birth, and it normally comes on relatively quickly. So I think we all worry about missing a psychosis. you're not going to, is probably what I'd reassure sort of clinicians about. They will present, it will be sort of abstract behaviors. You normally get partners or families as well saying, look, something is just really not right here. You know, sleep normally is completely disrupted, and then this psychosis sort of presentation then builds from there.
Yeah, I suppose it as a condition gets quite a lot of attention. I'm thinking about documentaries that I've watched about this. I think there was a Louis Theroux one, and it was focused on perinatal psychosis because I suppose it's interesting. It's a little bit novel for people to find out about. It's really good to hear. It's rare, but of course, I think it's just changing that mindset to think a lot more broadly about what perinatal mental health means to our patients and what we should be looking out for.
Yeah, absolutely. That it is such a wide variety of conditions because absolutely, if you ask most clinicians, they think about depression and psychosis, and that's all that's involved in perinatal mental illness. So it's just thinking more broadly that there is a wide variety of conditions there. And if we can then think about picking them up, we can then help women and families with them. And I guess that moves on to a bit what we talked about is about the treatment and how we can help these patients when we've identified it.
Yeah, I think that's really great. I think broadening that conversation and bringing us on to what we might be able to do about it. And it's been really wonderful exploring these topics today and looking at things more broadly. And I'm really happy that we're going to explore treatment options and that's in the final part of this series of podcasts. And we're going to be looking about what we might actually be able to do to impact on that. So thank you so much for today, Jenny, and look forward to speaking to you really, really soon.
Brilliant. Thanks, James.